Hello everyone, this is Dr. Masudan Rao on the program I teach medical students. The topic of today's lesson is pulmonary edema. I'm going to touch on this topic in relation to its definition, etiology, pathophysiology, clinical manifestations, and management. Well, what is pulmonary edema? Pulmonary edema is the condition with excessive accumulation of extravascular fluid in the lungs, resulting in some impairment of ventilation and oxygenation. If left untreated, it leads to respiratory failure and fatality. There is impaired ventilation secondary to the poor compliance of the lungs. Okay, there is a disturbance and impedance to the gases exchange between the alveoli and the capillaries, thereby resulting in hypoxia and progressive respiratory failure and death. Etiologically, pulmonary edema is two types, cardiogenic and non-cardiogenic. Okay, well, let us go about this. This picture shows the presence of pulmonary edema. Well, these are the lungs which are in health, normal alveolar sacs without any fluid, and normal interstitium. There is no fluid or in the alveoli or the interstitial compartment. Here in the lung with the pulmonary edema shows the presence of fluid in the alveolar sacs and also in the interstitial compartment. Well, this is the X-ray of the patient with pulmonary edema. Whereas edema is more so centralized, probably due to cardiogenic edema. Well, coming to the introduction, pulmonary edema is defined as excessive accumulation of extravascular fluid in lung parenchyma. It leads to poor compliance of the lungs associated with impaired ventilation and oxygenation. It interferes with the exchange of gases at the alveolar level, resulting in hypoxia and progressive respiratory failure. Etiologically, it is of two types, as I told you, cardiogenic and non-cardiogenic. Cardiogenic is due to inability to clear the blood in the pulmonary circulation, secondary to left heart failure. Non-cardiogenic is secondary to lung injury or systemic diseases that causes imbalance in hydrostatic and osmotic pressures across the pulmonary vascular bed and the interstitium. With relatively elevated hydrostatic pressure in the vascular compartment, which drives the fluid out of the capillary network into the extravascular compartment, resulting in pulmonary edema. There is also increased permeability of the capillaries due to injury or inflammation. Okay. This non-cardiogenic pulmonary edema is associated with various pulmonary and systemic disorders. This is multisystemic illness with regard to non-cardiogenic pulmonary edema. Okay. Both the conditions, pulmonary edema presents as progressively increasing dyspnea, cough, with crepitations at the base of the lungs, and hypoxia. So these are the salient features of pulmonary edema, that is, progressively increasing dyspnea, cough, with basal crepitations, and associated hypoxia. Coming to etiology. Etiologically, there are two types, as I told you, cardiogenic pulmonary edema and non-cardiogenic. But then what are the causes? The causes of cardiogenic pulmonary edema include myocardial infarction, acute myocarditis, cardiomyopathy, mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and arrhythmias. In all these conditions, there is some degree of systolic and diastolic dysfunction of the ventricles. That results in the increased hydrostatic pressure in the pulmonary capillaries. Okay, that results in the failure of clearance of the pulmonary circulation, resulting in pulmonary edema. In non-cardiogenic, it is due to increased vascular permeability. Increased vascular permeability of different causes, either due to the trauma or infection in the lung tissue, that is pneumonia, or due to systemic illnesses, okay, some toxigenic causes, septic, okay, inflammatory vasculitis, a part of the generalized vasculitis syndrome, results in the increased permeability of the pulmonary capillaries, thereby causing the translation of the fluid with high protein content that results in the pulmonary edema. Okay, acute lung injury with severe hypoxemia is described as acute respiratory distress syndrome and is seen in several conditions associated directly or indirectly affecting the lungs. Okay. Coming to pathophysiology, it is because of the disruption of the balance of hydrostatic and oncotic pressures across the vascular membrane between the intravascular and interstitial compartments. Okay, there is a barrier, there is a vascular barrier which is disturbed. Okay, there is hydrostatic pressure, which is a driving force of the fluid from the vascular compartment into the extravascular compartment. Increasing hydrostatic pressure results in the shift of the fluid from the intravascular compartment into the extravascular compartment. In the same way, rising oncotic pressure in the interstitial compartment pulls the more fluid from the vascular compartment into the interstitial compartment. Okay. In normal individual, there is a balance between these two forces. That is, balance between the hydrostatic and oncotic pressures. Okay. Usually the fluid from the extravascular compartment moves into the capillaries, capillary end of the arterioles. But in conditions such as the cardiogenic edema, there is rising hydrostatic pressure in the capillary end of the arterioles. Okay, so the fluid moves out of the capillaries into the interstitial compartment, thereby causing pulmonary edema. Okay, because high capillary pressure, hydrostatic pressure in the capillaries prevents the clearance of the blood from the pulmonary circulation, or the movement of the blood from the pulmonary circulation into the capillaries, thereby venous return to the left heart. Okay, because of high capillary hydrostatic pressure, it causes impedance for the movement of the blood from the pulmonary arteries to the capillaries. So more amount of fluid leaks from the capillary end into the interstitium, thereby causing pulmonary edema. Well, if there is vascular element, that is, there is vasculitis, that is inflammation or injury to the vascular bed, results in the leakage of the fluid containing high protein into the interstitial compartment. Presence of protein in the interstitial compartment raises the oncotic pressure in the extravascular compartment, thereby causing movement of the fluid from the capillaries into the interstitial compartment. Okay. Either due to rise in the hydrostatic pressure in the vascular compartment or elevated oncotic pressure in the extravascular compartment. Both these situations results in the movement of the fluid into the interstitial compartment, thereby causing pulmonary edema. Okay. Well, elevated hydrostatic pressure in the pulmonary capillaries as a result of backward pressure from the left ventricle or ventricular dysfunction results in the movement of the fluid from the capillaries to the extravascular. So, the increased permeability of the capillaries secondary to the vasculitis syndrome results in raised oncotic pressure due to movement of the protein-rich fluid into the interstitial compartment. Okay? So, in both these conditions, there is excessive fluid in the interstitial compartment. That is the cause of pulmonary edema. Okay, this is what happens in the situations like cardiogenic or non-cardiogenic pulmonary edema. In cardiogenic edema, there is rising hydrostatic pressure in the capillaries. In the non-cardiogenic edema, it is because of the vasculitis and the increased permeability of the capillaries that results in the movement of the protein-rich fluid into the interstitial compartment. Okay. Further aggravating the movement of the fluid from the intravascular compartment into the interstitial compartment due to rise in oncotic pressure in the extravascular compartment. Okay, this is what happens in both the types of pulmonary edema. That interferes with the gaseous exchange between the capillary blood and the alveoli, because the barrier gets thickened and there is poor compliance of the lungs. So ventilation is affected. And there is impedance for the gaseous exchange because of the presence of fluid in the interstitial compartment, thereby causing hypoxia and respiratory failure. Well, how does the patient presents clinically? This acute onset of severe breathlessness progressively increases in severity, presenting with tachypnea, hypoxia, and you can appreciate presence of basal contractions when you auscultate. Okay. This is what happens in both the types of pulmonary edema, say cardiogenic or non-cardiogenic. Patients present a sudden onset of severe breathlessness, tachypnea, tachycardia, and hypoxia, and presence of basal crepes when you auscultate the chest wall. In cardiogenic pulmonary edema, in addition to the above findings, there could be cough with expectoration of pinkish, frothy sputum and presence of wheezes. And in cases of cardiogenic edema, there could be presence of pleural effusions. We find more commonly in cardiogenic pulmonary edema. Okay, you will appreciate the fine crepitations at the end of inspiration in cardiogenic edema. In non-cardiogenic edema, the patient may present with the presence of acute onset of fever, which is persisting, breathlessness and cough and expectoration. Okay, and presence of basal crepitations and signs of pneumonia, or there could be signs of impending shock with hypotension and tachycardia, and signs of sepsis resulting in septic shock. Okay, and the patient may present with the acute respiratory distress syndrome, ARDS. So these are the features of non-cardiogenic pulmonary edema. And there could be manifestations of the extrapulmonary illnesses which are responsible for the pulmonary edema and acute respiratory distress syndrome, like sepsis, etc. With the clinical history and detailed clinical examination, in presence of tachypnea, tachycardia, signs of hypoxia, presence of crepitations, presence of pleural effusion, and in the evidence of history of chest pain simulating acute myocardial infarction, presence of other systemic illnesses, okay, you made a provisional diagnosis of either cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. Okay, then proceed with the laboratory evaluation. Go with the blood levels of brain natriuretic peptide. Okay, this is elevated in cardiogenic pulmonary edema. And if you take the X-ray chest, in cardiogenic pulmonary edema, the opacities are more centralized. Okay, you see, you will find the curly B lines, presence of pleural effusion, and peribronchial cuffing. Whereas in non-cardiogenic edema, there will be patchy opacities at the peripheries and presence of consolidation, okay, and air bronchograms, etc. And go to the ECG, will demonstrate the presence of cardiac injury and myocardial infarction. And echocardiography demonstrates the presence of valvular diseases, myocarditis, okay, cardiomyopathy. Then go for the serum electrolytes and other renal functional tests, blood counts to show the presence of systemic infection. And troponin levels will show you the presence of acute myocardial infarction. Serum amylase and lipase levels will demonstrate you presence of pancreatitis. And gold standard test, that is pulmonary arterial pressure. With the cardiac catheterization, assess the pulmonary arterial pressure to confirm the presence of pulmonary hypertension and pulmonary edema. Lung ultrasound is currently carried out at the point of care management to demonstrate the presence of pulmonary edema. Having completely evaluated the patient, simultaneously go to the emergency treatment. The goal is to alleviate the symptoms, put the patient on the oxygen to alleviate hypoxia, then treat the underlying condition. Diuretics in high doses intravenously administered will improve the pulmonary edema. Okay, may complicate in certain occasions transient renal failure. But by and large, you give the high doses of diuretics to improve the pulmonary edema at the point of care. And along with the oxygen administration to treat hypoxia. Vasodilators are given in the form of nitropsamine or nifedipine. Okay, they will help in reducing the preload. Okay, thereby reducing the right ventricular output and pulmonary congestion. Inotropes. Inotropes are going to improve the presence of hypotension. They limit the peripheral congestion, thereby reducing the venous return. Oxygen therapy to correct the hypoxia, and antibiotics to treat the infection. This is the major line of treatment in brief. prognosis. It is very difficult to, document the prognosis because several etiological factors are associated with the both types of cardiogenic as well as the non-cardiogenic pulmonary edema. It is prognosis and of the factors of the illnesses involved that are responsible for the pulmonary edema, and the response of the treatment and recovery from the associated several disorders which are responsible for the pulmonary edema determines the prognosis. Okay, so by and large, with the advanced management and early treatment, the patients are improving, and the percentage of the mortality has been coming down in the current literature. Prognosis in the current report says it is good in 30 to 40% of the patients when compared to 60 to 80% of mortality in the earlier reports. Complications, that is, cardiogenic pulmonary edema may complicate with respiratory failure, may require ventilator support. In the same way, acute lung injury with ARDS may also require ventilator management. If they fail to respond to these measures, ECMO is the final line of management to make the patient recover from the dreadful pulmonary edema, which is not responding to routine treatment. Thank you very much for patient listening. And this is what I can give you a brief note, brief description on the pulmonary edema. My dear students, if you like my video, please subscribe to my channel, and we'll meet you again in the next class. Pulmonary edema is something as two types, as I told you in the beginning. You must be mindful of the early diagnosis of this particular dreadful condition and arrive at the provisional diagnosis as early as possible, and institute the early treatment with the high doses of diuretics in order to get the patient relieved of pulmonary edema, and also simultaneously correct the hypoxia in order to reduce the morbidity and mortality. Thank you very much for patient listening. We'll meet you again in the next class. Until that time, bye-bye. Thank you once again.